in order to understand the site of lesion and its potential impact on the lower urinary tract, Dr. Nazim, who's an associate professor at Khan University, is going to talk about the level of lesion and impact on urinary tract. So remember, these two are very important presentations, after which we're going to move on to the clinical aspects, starting from urodynamics to overactive bladder and BPH in male looks. So over to you, Nazim.
Thank you very much, Dr. Hamad. So I'm glad and I'm very thankful to Dr. Ahmed. He has made a very good presentation, a very simple but very good presentation to clear the concepts. Right, so there is some technical issue. Right, thank you. So we are going to talk about the pathophysiology of neurogenic bladders. So lower urinary tract, which includes urinary bladder, urethra, and muscular urinary sphincter, is complex. And it requires intact nervous signal conduction and modulation at the peripheral level. So this includes the coordination between the nerves of pelvic region as well as neuronal centers in spinal cord and the brain. And this complex nervous network permits a smooth switching between the two principal but opposing functions of the lower urinary tract, which is the storage of urine in the bladder at low pressure and periodic voluntary total emptying of the bladder during voiding. So this is being explained by Dr. Ahmed, but I'm just going to give you a brief neuroanatomy. So he talked about the cortex. So cortex mediates the sensation and voluntary initiation of micturition. The pontine micturition center or periaqueductal gray, it mediates the coordination between the bladder and sphincter and helps to complete the voiding. And the spinal reflexes are generated at the sacral micturition center. And this is the, basically, this mediates the reflex bladder contraction, what he called as vesicospinal vesical reflex. Again, in the sacral part of the spinal cord lies the onus nucleus, which controls the pudendal nerve and causes the guarding reflex. The sympathetic nervous system, starting from T10 level of the spinal cord to L2, mediates the receptive relaxation and inhibits the bladder contraction during the filling phase of the bladder. So I will skip through this slide. This is basically about the switching between the storage and as well as the voiding function of the bladder with the role of cortex and the pontine micturition center that Dr. Ahmed has already covered. The disturbances in nervous system leads to neuro-urological symptoms depending upon the extent of the lesion as well as its location. The patients with neuro-urological conditions can be symptomatic or asymptomatic and can develop a variety of complications, including urinary incontinence, recurrent UTIs, hydronephrosis, and eventually even renal failure. And this all is accompanied by negative impact on quality of life because of incontinence and UTIs, etc., and bothersome lower urinary tract symptoms. However, it is important to note that symptoms and long-term complications, they do not correlate. And it is important to identify patients with neurological symptoms. A neuropathic bladder is not just a dysfunctional normal bladder because the bladder is normal, but the control systems are impaired or absent, leading to impaired or loss of voluntary voiding, and again the continence can be lost or impaired. I will just quickly go through the 2021 EAU guidelines, recommendations for history, physical examination, and some of the level of evidence for suspected neuro-urological conditions. So they say that during the history taking, one must identify and ask for the specific urinary symptoms, such as what was the onset, what about the bladder sensation, whether the initiation of micturition is normal, precipitate, or reflex, is it accompanied by enuresis, and the other lower urinary tract symptoms questions, including the incontinence and mode and type of voiding. Along with that, the past history is important, particularly the milestones, the heredity of familial risk factors, obstetric history, particularly in females, obviously in females, the history of diabetes mellitus, and accompanying diseases like history of CVA in the past, syphilis, encephalitis, or multiple sclerosis. any history of previous operations or accidents, history of medications, and history of alcohol consumption, smoking, etc. Apart from the urological history, because the neurological conditions impact the sexual system, the bowel, as well as other neurological systems. So this history is also important, particularly whether the patient has sensation in the genital area in the males about the erection, the orgasm, and whether the ejaculation is present, whether it is retrograde or there is an ejaculation, and in female, the lack of orgasm and dyspareunia. With regard to bowel history, whether the patient feels the desire to defecate, what about the rectal sensation, and what about the frequency of bowel movements, and is there any history of fecal incontinence? And about the neurological history, whether there is any acquired or congenital neurological condition, what about the patient's cognitive function, comprehension, and mental status, and what about the neurological, somatic, and sensory neurological conditions, and about the patient's dexterity and mobility. The physical exams must include the examination of reflexes pertinent to lumbosacral spinal cord levels, such as the bulbocavernous reflex, the perianal anal reflex, the anal tone, the knee jerk, the knee and the ankle reflexes, and prostate must be palpated because that can complicate a benign enlarged prostate can complicate the matter further, and whether there is any prolapse of pelvic organs. So the recommendation of EU guideline is that one must pay attention to existence of alarming signs such as pain, infection, hematuria, and fever, which warrant further diagnosis. And apart from history and physical examination, a routine urinalysis, blood chemistry, voiding diary, measurement of post-void residual volume and UFM, the quantification of incontinence and urinary tract imaging is of utmost importance. Urodynamic investigation is the only method that can objectively assess the dysfunction of lower urinary tract. So now moving on to the localization of the lesion and the impact on the urinary system. So again, the knowledge of neuroanatomy and neurophysiology helps to predict which type of lower urinary tract symptom abnormality may arise from the lesion. And this lower urinary tract dysfunction, the vesico-sphincteric pattern, is dictated by a number of the factors. This is very important to remember that the level of injury is very important, be it in the brain area, in the brain stem area, in the spinal cord, at which cord level, or at the level of peripheral nerves. What is the severity of injury? Is it complete? Is it partial? Is it a one-time injury, or is it one-time lesion, or is it gradually progressing over the period of time? What is the etiology? Is it reversible or is it destructive? Is there any previous history of concomitant neurological conditions or urological conditions such as BPH or vaginal prolapse, and how the symptoms have progressed over the period of time? So this is a diagram where you can see, and the lesions can be classified at 4 levels. So this is the area of pontine micturition center in the pons. So the lesions can be classified as suprapontine lesion, including the areas of forebrain and midbrain. The lesions can lie between the pontine micturition center or at pontine micturition center and above the sacral part of the spinal cord, which is called as suprasacral lesions. Lesion can lie at the level of sacral spinal cord, and lesion can lie at the level of cauda equina or peripheral nerve. And all these have varying signs and varying impact on the lower urinary tract. So this is a diagram, a schematic representation of the previous one, but it is important to realize on over here you can see the spinal cord, and over here you can see the level of the vertebra. So in adults, the vertebral level and spinal cord level do not lie adjacent. You can see that the thoracic spinal cord finishes somewhere at the level of T7, T8 thoracic vertebra. And similarly, the spinal cord ends at the level of L1 lumbar vertebra, beneath which lies the cauda equina. So let's take an example. So if a lesion lies at this level of the thorax, at this level of the vertebra, that is, if there is, for example, a T12L1 prolapse of intervertebral disc, then it will not affect the T12 or L1 level of the spinal cord. Rather, it will affect the sacral part of the spinal cord. So now this is the next few slides will talk about the location of lesion with associated neurogenic lower unit tract symptom, lower unit tract dysfunction, and what symptoms and signs the patient would exhibit, and few examples of those neurological lesions. So suprapontine lesion is a neurological lesion above the level of the pons, and once there is a lesion in the above the level of the pons, so the inhibition of pontine micturition center by cortex is lost. So there will be a reflex detrusor contraction, there will be impaired cerebral regulation and central inhibition, but as the pontine micturition switch is intact, therefore there is synergistic widening and there is a synergy between the bladder and sphincter. The bladder sensations are often preserved. The symptoms and signs that patients have, they have urinary frequency, urgency, urge urinary incontinence, reduced awareness of bladder fullness, very less often they have some of the voiding symptoms, and deterioration of upper urinary tract is uncommon because there is no detrusor sphincter dyssynergia. Example includes cerebrovascular accidents, brain tumors, Parkinson's disease, and multisystem atrophy. So a lesion at the level of the cortex will lead to the patient not knowing whether his bladder is full or not, and whether it is a right time and place to void. And the impact on the pontine micturition center is lost. So in a suprasacral spinal cord lesion, the lesion lies in the suprasacral part of the spine or at the level of the pons. What abnormality will you find on urodynamic studies as well as in the bladder will be detrusor overactivity and incontinence with or without detrusor sphincter dyssynergia. There is often significant post-void residual volume, and these bladders are not safe because they are high pressure bladder. Patients usually exhibit both storage and voiding symptoms, and because of the high pressure bladder and DSD with raised PVR, there is significant threat not only to the bladder but to the upper urinary tract, and with subsequent repeated UTI and progressive bladder and upper tract deterioration, patients may eventually end up with the with end-stage kidney disease. Examples of this condition include traumatic spinal cord injuries, multiple sclerosis, the myelodysplasia such as meningomyelocele involving the thoracolumbar level of the cord, and myelitis of different etiology. Now, the injury or lesion at the level of sacral spinal cord can involve both the detrusor or parasympathetic nucleus as well as the onus nucleus, or it can predominantly affect either of these nucleus. In cases whenever there is injury or lesion to the detrusor nucleus, this is called as type A, mixed type A sacral spinal cord lesion. Because there is no parasympathetic drive, there will be detrusor areflexia and the detrusor will be acontractile. The sphincteric function is intact because of the intact onus nucleus. In mixed type B, which is less common as compared to mixed type A, the onus nucleus is disturbed, so there will be impaired sphincteric activity. However, because of the uninhibited detrusor nucleus, the bladder will be spastic. Patients will exhibit signs and symptoms of stress urinary incontinence with poor flow, Valsalva voiding with interrupted flow, and in cases of type A, there will be overflow incontinence. Conditions that lead to sacral spinal cord lesions include traumatic spinal cord lesions at the level of sacral cord, lumbosacral myelodysplasias, and sacral malformations. The infrasacral lesions include neurological lesions that affect the quadrata equina or peripheral nerves. Again, the bladder will be acontractile and it might accompany the stress urinary incontinence. There will be large capacity bladder with overflow incontinence. Example includes peripheral nerve conditions such as poorly controlled diabetes mellitus leading to diabetic cystopathy, and extensive pelvic trauma as well as radical pelvic surgery, radical pelvic gynecological, urological, or colorectal surgeries that can lead to infrasacral disturbance and urological symptoms. Mixed neuronal lesions include lesions of the neuronal pathways at the different levels of central nervous system. And because of involvement of the different levels, maybe such as mixed neuronal lesions are common in multiple sclerosis, which can affect the brain, the peripheral nerves, and the spinal cord. So the picture will vary, and these are the complex lower and lead to complex lower urinary tract dysfunction. And these conditions are often progressive, and in association with other conditions like diabetes and BPH, the signs and symptoms often progress and varies with the period of time. So this is the summary. So suprapontine lesion has patients with suprapontine lesions have predominantly storage symptoms. Ultrasound shows insignificant PVR volume, and urodynamics shows detrusor overactivity. This is a diagram which shows that in the suprapontine lesion, the bladder is overactive and sphincter is normoactive. In the suprasacral spinal cord lesions, what happens that because the coordination is lost, so patient has both storage as well as voiding symptom, there is increased PVR. Urodynamic studies shows DSD as well as detrusor overactivity. So this shows that both sphincter as well as the detrusor are overactive. At the sacral and infrasacral level lesion, there will be predominantly voiding symptom because of areflexic bladder. Post-void residual volume will be raised on ultrasound, and urodynamic study will show hypocontractile or acontractile bladder. Now, moving on to the specific entities and their impact on the lower urinary tract. So spinal shock is a condition which is an initial temporary phase following an acute neurological insult, such as cerebrovascular accident or spinal cord injury. Immediately after this insult, there is loss of sensory, motor, and reflex activity below the level of injury, and there is temporary, complete, painless urinary retention, along with bowel and sexual conditions. So the transition is that within the days, the bowel sound starts to appear. In days to weeks, somatic reflexes appear, and there is a spasticity in the muscles. Within weeks to months, the bladder becomes reflexic. The bowel also show reflex activity and erections start. In months to year, if the injury is incomplete, the patient may gain voluntary movement and urethral sphincteric control. The ejaculatory functions are the ones which are the last one to recover. Another condition is autonomic dysreflexia, which usually accompanies injury to the thoracic or cervical spine, upper thoracic or cervical spine above the level of T6. What happens in this condition, which is a potential medical emergency, whenever there is a stimulus in the field of distribution of autonomic sympathetic nucleus, there is an unregulated sympathetic function below the lesion, and there is a compensatory autonomic response characterized by hypertension, bradycardia, piloerection, severe headache, and flushing above the level of the lesion, with pallor below the level of the lesion. And sometimes it leads to conversion and hypertensive crisis. Treatment includes removal of the cause, moving the patient to the upright position. If the catheter is in place, it is blocked or leads to UTI, you need to change the catheter. You need to bring the blood pressure down by GTN spray, sublingual captopril, or sometimes IV, use of IV labetalol. Now, spinal cord, whenever a patient has a spinal cord injury, so there are certain description that needs to be done or that needs to be described with that spinal cord injury. So you need to know the last segment which has a near normal function. So for example, if the injury is at the level of thoracic T6 spine, it may involve T6 and beyond, maybe up to T8, maybe up to lumbar level as well. But you must know the last normal functioning segment of the thoracic, of the spinal cord at that level. Whether the injury is complete or incomplete. If it is incomplete, what is the pattern and what is the severity? And what is the type of paralysis? Is it spastic or is it flaccid? So whenever there is spinal cord injury, there is spinal shock characterized by areflexes, reflexic bowel and bladder, and flaccid paralysis. If it involves a long segment of the cord, including the sacral as well as lower down segment, there will be flaccid paralysis and areflexic bowel and bladder, which will continue for the rest of the period. If it is incomplete injury, or if it is limited to a small area of the spine with intact sacral and infrasacral portion of the cord, then there might be a spastic paralysis and bladder and bowel will be reflex. Now, talking about the effect of length of the lesion. So you can see that in both of the diagram, the injury or lesion lies in the upper thoracic level. But here you can see the injury is confined only to a small portion of the thoracic spine, while in the right side of the diagram, you can see the injury involves much more thoracic portion of the cord as compared to the left one. So this is the example of certain conditions, the congenital conditions, acquired conditions, and the conditions which progress over the period of time. So the brain conditions which can have neuropathic bladder include, the congenital conditions include cerebral palsy, acquired conditions include stroke, head injury, and the progressive conditions might include multiple sclerosis, Parkinson's disease, and dementias. For the suprasacral spinal cord lesions, the common congenital conditions include neural tube defects such as meningomyelocele. Acquired conditions include spinal cord injuries, and progressive conditions include cervical and lumbar spondylosis, multiple sclerosis. For the sacral spinal cord and peripheral nerve conditions, again the congenital conditions that involve include meningomyelocele, sacral agenesis, and anorectal anomalies. Acquired conditions include caudate venous syndrome, spinal cord injury, and peripheral nerve injury from radical pelvic surgeries. And progressive conditions might include peripheral neuropathy because of the acquired conditions. I will just briefly touch upon 4 or 5 conditions which can have impact on the lower urinary tract system. Dementia is a condition, debilitating condition, which is characterized by atrophy and loss of both gray and white matter. It predominantly affects the frontal lobe, which mediates the task related to memory and mentation. So most of these patients with dementia have urinary incontinence because of both of these factors. First, there is loss of cortical control over pontine micturition center. So patient lose the awareness of desire to voluntary void with having retrusor overactivity. We all know that Parkinson's disease is a neurodegenerative disorder because of the degeneration of neurons in the substantia nigra. And this disease is characterized by bradykinesia, rigidity, and tremors. Majority of patients present with overactive bladder symptoms, but they might have detrusor underactivity, DSD, and bladder outflow obstruction. Multisystem atrophy is also known as Child-Drager syndrome. It's a progressive neurodegenerative disease of unknown origin, and it is characterized by late diagnosis, and patients generally have symptoms for years, urological and neurological symptoms for years before the diagnosis is being made. Patients exhibit signs of Parkinson's disease along with cerebellar, autonomic, and pyramidal dysfunction, and lower urinary tract symptoms are much more bothersome. It leads to decreased bladder compliance, detrusor overactivity, and patients have difficulty in initiating and maintaining the voiding. Multiple sclerosis is a demyelinating disease of central nervous system, which is characterized by relapsing, remitting, and progressive course. And it involves optic nerve, pyramidal tract, abnormality leading to ataxia, poor bowel function, lower urinary tract symptom, lower urinary tract dysfunction, and sexual dysfunction. And signs and symptoms vary among the patients because the lesion can present anywhere between the brain as well as in the spinal cord. Spina bifida can be spina bifida occulta or spina bifida cystica. And patients with neural tube defects, majority, over 90% are affected by lower urinary tract. The meningomyelocele involves the lumbar, lumbosacral, and sacral part of the spinal cord in more than 90% of the patients. And even if it is fixed early in the life, the symptoms change later in the life because of the subsequently after the surgery because of the tethering of the spinal cord. Most of the patients with neural tube defect or spinal dysraphism, they present with areflexic bladder along with open bladder neck leading to urinary incontinence. The caudate venous syndrome is characterized by, is because of the injury to the peripheral nerves or caudate vena due to the disc protrusion, spinal fracture or iatrogenic lesions, secondary to the spinal surgery. It affects the motor and sensory symptoms of the lower limb, buttock, perineum with abnormalities of sexual, bowel, and bladder function. Patients usually have urinary retention with associated underactive detrusor and loss of the bowel sensation, and they present with overflow incontinence, poor compliance, and detrusor overactivity. Now I will move on to 4 or 5 clinical scenario and would ask the participants to give their input in the chat box as well. So here you can see few of the mine workers who are working in a coal mine, and suddenly the mine collapses, leading to injury to the thoracic spine, and there is this complete transaction of the thoracic spine at the level of T7, T8. This is another patient who had a history of fall on his head, leading to injury to the cervical part of the cervical spine and cervical part of the spinal cord. So this is actually a suprasacral and supraconal lesion and leading to spastic spinal cord injury. So this is the diagram over here. So can anyone tell me what are the impact and how would detrusor, how would bladder, bowel, etc. will behave in this scenario? So please write in the chat box. So no comments. So the sensations, there will be autonomic symptoms. The coordination will be lost. Completion of voiding will be lost. And there will be, because of the suprasacral lesion, there will be dyssynergic reflex voiding with poorly sustained bladder contractions, poor compliance, and leading to a potentially unsafe bladder. The next scenario, a young child with history of injury to his brain. This is a CT scan. You can see that there is injury to the frontal lobe along with the fracture of the skull. So this is a suprapontine lesion. So the control of pontine micturition center is lost. So what are we expecting in this situation? Please write in the chat box. Right, so Mohammed Shoaib has written high bladder pressure, overactive bladder, Dr. Nazish Mughal, right? You're right. Sorry. Yes, so the voluntary initiation would be lost because the cortical control is gone. However, there will be coordinated reflex voiding and there will be some social incontinence. But remember, Dr. Shoaib, that the pontine micturition center, since it is intact, so there will be no detrusor sphincter dyssynergia, detrusor overactivity will be mild. So this bladder would be probably safe. Now moving on to the spinal injuries and the lesions at the level of the spinal cord. So this is, so anyone can tell me where exactly the lesion is. So this is the cortex, brainstem, cervical part of the spinal cord, thoracic, lumbar, and sacral part. This black area is the complete injury or complete lesion, and the dotted area is actually the partial area of the cord damage. So where exactly the lesion lies? Anyone? So this is actually a T2 spastic paraplegia. Remember, you must know the normal part of the cord, normal functioning cord. So the T2 must be over here. So this is a T2. This will be a spastic paraplegia because the sacral part is intact and this is a cord injury. So because the sacral part will be intact, so what will happen to the bladder, bowel, and sexual function? Dr. Nazish is right, this is suprasacral, but if you characterize the lesion, it will be spastic. Right, so DSD, okay, DSD is fine, but whether the bladder will function or not. Bladder will be high pressure with upper tract inflate, very good. Detrusor and bladder will be overactive, very nice. So bladder will have a reflex activity, bladder, because the sacral part is intact. So bladder will have reflex activity. So bladder will be reflex. What about bowel? incontinence. So why there would be incontinence? Do you think sphincter is gone? The perineal muscles and the pelvic floor muscles are weak or not? So the sphincter will be intact because the pudendal nerve is intact. So there will be no fecal incontinence. Again, the bowel would be again a reflex bladder. What about sexual function? What about erection? What about ejaculation? So erection is intact, right? So erection would be intact, but will patient be able to, initiate the erection or not? Dr. Sana has mentioned that ejaculation would be effective. So the injury is confined. It starts from T2 and it is actually ending above the level of the sympathetic output. Above it finishes. So the thoracolumbar part of the parasympathetic output is intact. So the patient would not be able to achieve erections, but will have reflex erections and reflex ejaculations. But the injury being in the upper thoracic area, patient would exhibit the autonomic dysreflexia. Next thing, so the injury is over here. It involves the lower thoracic and upper lumbar part of the cord. So the injury is T10, is spastic paraplegia. What is the impact on bowel, bladder, erection, and ejaculation in this case? So because the sacral part is intact, so bladder will be reflex, bowel will be reflex. As this area, this level of lesion involves the thoracolumbar sympathetic outflow, so there will be absent ejaculation. But because the parasympathetic system in the sacral part is intact, there will be reflex erections. There will be some autonomic symptom, but no autonomic or sympathetic dysreflexia because the lesion is in the lower thoracic part of the cord. So this is a lesion which is starting at T6 level. So the normal part of the cord is T6, but the lesion or the injury is extending all the way down to the sacral part of the cord. So will this be a spastic or flaccid paralysis? So this will be a flaccid one. So this is a T6 flaccid paraplegia. Because sacral part is gone, so bladder will be areflexic. What about bowel? What about erection? What about ejaculation? So you can see here that the incontinent bowel, okay, because the sphincter function is gone, areflexic, very good. The thoracolumbar sympathetic as well as the parasympathetic output is gone. So the patient will have areflexic bowel, absent erections, absent ejaculations, and because the autonomic system is gone, so there will be no autonomic symptom and no autonomic dysreflexia. This is the conus injury, isolated conus injury. So there will be low flaccid paraplegia, areflexic bladder, areflexic bowel. There will be some psychogenic erections, because a portion of sacral part is intact, and there will be psychogenic emission because the parasympathetic part is also intact. So this is the last slide. Again, this is for the third time we are reviewing this. So in the brain conditions, for example, in the CVA bilateral or CVA or central lesions, or in the cases of brain tumors, etc., what happens to the bladder? The bladder becomes overactive. There is neurogenic detrusor overactivity, and it is less common to have an underactive bladder. What happens to sphincter function is usually normal, and the bladder and bowel activities are coordinated. In suprasacral spinal cord lesion, what happens to the bladder? The bladder becomes overactive with neurogenic detrusor overactivity. Sphincter function, there is uncoordinated sphincter activity with the bladder leading to detrusor sphincter dyssynergia. And in cases of sacral as well as peripheral nerve conditions, the bladder would be underactive. There will be impaired bladder compliance in some cases, and particularly later on because of the subsequent fibrosis. And sphincter function is also underactive. Thank you very much.